Moving on to the next session, community ophthalmology semifinals. I'd like to invite our judges, Dr. Asim, Dr. Rohit, and Dr. Anil.
Yes,
Good
I'm
afternoon,
ready.
Dr. Asim.
Good afternoon.
Dr. Anil.
Yeah, I'm here.
Good afternoon, sir. And Dr. Rohit.
Yeah, I am here.
Good afternoon, doctor.
Afternoon.
Our first presenter is Dr. Sanita Satyan.
Sir, I'm here.
Yes, ma'am. Please share your screen.
Is it visible, sir?
Yes, sir. Yes, ma'am.
Okay, can I start? My title is Can Stereo Acuity Replace Visual Acuity in Amblyopia Risk Factor Screening Among Preschoolers? We know preschool vision screening is aimed at timely detection of amblyopia and its risk factors. The conventional methods include age-appropriate visual acuity charts. And this requires good comprehension, attention span, and it is a resource and labor-intensive, time-consuming procedure. So is there an alternate way to screen preschoolers more efficiently? We know binocular vision is affected early in cases of refractive errors, strabismus, and media opicities, which can be very well detected by stereo acuity test even in very young children. This is less time consuming also. So our research question was, can stereo acuity test replace visual acuity based test in preschool screening? The aim of our study was to compare the efficacy of Lee symbols or HOTV charts and TNO stereo acuity charts in screening for amblyopia and its risk factors among preschool children between 3 to 6 years of age. This was a comparative observational study of 634 children. We excluded those with unreliable measurements and neurological deficits, and informed consent letter was obtained from the parents. And this screening was done in the preschool premises in a dedicated space. And the charts used were Lee symbol charts and HOTV for visual acuity. And these charts were familiarized to the children in the form of a pre-test with the optotypes. And then near stereo acuity estimation was done using TNO stereo test. These were the visual acuity cutoffs. This was based upon age, and stereo acuity cutoff was 240 seconds of arc. We also performed corneal reflex ocular movements, cover test, non-mydriatic retinoscopy, and flashlight examination. Fail in any of this meant referral. And data was statistically analyzed. We had a good distribution of different age groups, and this was the mean presenting visual acuity and the mean stereo acuity among the different age groups. So this is our result. All the children underwent the two tests, out of which 85% showed agreement in terms of referral. But 15% of children did not show agreement between the two tests in terms of referral. This is a significant number. And again, when we tabulate in a 2x2 column, we can see that those children who actually failed visual acuity had passed TNO test. There were 49 children like that. And those who actually passed the visual acuity, 48 of them actually had failed the TNO test. And this was statistically significant in the total sample, as well as in the 3 years, 4 years, 5 years, and also 6 years age group. And this was a referral rate based upon this calculation. For example, if we take 3-year age group, and 42.42% children were detected by TNO test, whereas for referral, whereas only 24.24% were detected when detected by visual acuity test alone. This pattern was similar in 4 years also, and again 5 years and 6 years there was a more or less equivocal response. And failure to detect with a single screening test alone was used, and this was many children who were missed in visual acuity screening were detected in TNO screening. For example, in 3 years, again, 21.21%, which was similar in 4 years also. So, so we also tried to compare the referral rates. What would be the referral rates if combination of tests was used? As we have imagined, like combination was definitely better, and referral by combination was definitely better, but referral was better with TNO in the 3 years and 4 years, and equivocal in 5 years and 6 years. And coming to the discussion part, the most important thing, there is a significant difference in the referral rates by visual acuity charts and the TNO test, which was statistically significant in all the age groups. And this was the disparity observed in 15% of population. And these children, if they had undergone just one test, they would have been detected falsely as normal, and then they would not be referred. So we are losing this wonderful window for early treatment of amblyopia in these preschool children. And 3 and 4 years, TNO fared better, had better detection rates than visual acuity charts. And in 5 and 6 years, TNO and visual acuity charts were comparable. And this, again, was an interesting finding. And our explanation is that in the younger age groups, hyperopia is more prevalent. And hyperopia, as we know, is more amblyogenic. If you are using a distance visual acuity chart, you can have this moderate hyperopia and significant astigmatism are likely to miss, because they cannot be detected by a visual acuity test. So since 3 to 4 year children had more of hyperopia, this would be the reason they fared well in TNO and less in visual acuity charts. By 5 and 6 years, the children are entering the age of emmetropization, and they could better comprehend the charts. This could be the reason for equivocal response. So to conclude, TNO detection rates were better in 3 and 4 years, equivocal in 5 and 6 years. Between the two charts, and combined screening reduced false positives and increased true negatives. Pass in a simple distance visual acuity screening test or TNO test individually does not eliminate the need for further evaluation in this young children. Combination of visual acuity and stereo acuity test are best recommendations. If the combinations is not possible due to time or resource, in 3 and 4 year old, go for a TNO, which would give you better detection rates, and 5 and 6 years, please go for either of the charts. Thank you.
Thank you so much, ma'am, for the wonderful session.
Thank you, sir.
Judges, any questions, please?
How did you approach the children, either through ASHA workers or whether as a preschool children only?
No, sir. This was a community initiative by a tertiary care center. So our team, consisting of a optometrist and a PRO, actually approached the preschoolers, and then permission was taken, and then we went on with the screening.
Because you said you actually told them earlier. So whether that training of the student, the children was done by those workers, or it was done by your team only?
Okay, by our team only. What we did was to familiarize children with Lee symbol charts, because they contain many culture specific charts also. So our optometrists would go initially, and then they would introduce a song, a rhyming kind of song using the 4 charts, so that children would get an idea that this is an apple, this is a square, and this is a circle. And after this pre-testing only, we took them to the optotype kind of test.
Okay, good.
So,
I have one question.
what are the previous references? Any similar kind of study done in other countries?
Yeah, actually, there are references from the US task force recommendations for preschool screening. And then they had also recommended that for detecting hyperopia and mild amounts of astigmatism, this visual acuity charts like Lee and HOTV have an inherent fallacy regarding that, because they could be missed by they could miss hyperopia and other this also astigmatic kind of diseases also. And previously this idea was implemented, sir, and but it was more of the age group was different, and there are US based studies on this.
One question. Can I ask, is there time?
Yes, sir.
Sir, only 10 seconds are left.
Okay, so the question is like, what was your gold standard against which both the test was compared?
Yeah, The ideal gold standard would be a cycloplegic retinoscopy, but this was not done because it was a screening kind of procedure. And this was done from a community public health perspective, so that we just measured which test detected referrals more.
But based on that, you can't recommend which one to do, because unless
no, we cannot. We have not done a validity test because it was not possible to call all children and do cyclo at the first phase of the study. But we are planning
would be
for
to do in the clinics actually and
Yeah.
validate it rather than do
Okay.
in the community.
And that is the ideal form. We are. It is a work in progress, sir.
Thank you, ma'am.
Yes, sir.
Thank you, doctors. Moving on to the next speaker, I'd like to invite Dr. Mihir. Dr. Mihir Kothari. Judges, I think Dr. Mihir Kothari isn't there. So can we move on to the next speaker?
Please go ahead. If he joins in 10 minutes, that's fine.
Okay, sir. Our next speaker is Dr. Praveen Vashist. Sir, are you ready?
Yeah, I am here. Yeah, sure.
Sure. Please, sir, please share your screen.
I hope my screen is visible.
Yes, sir.
Just wait. Yeah. Thank you.
Yes, sir. Please start.
Good morning, respected judges. Today I am presenting the finding of National Survey on Human Resource and Infrastructure for Eye Care Services in India. The survey was led by RP Center, along with the partners, National Program for Control Blindness and Visual Impairment, All India Ophthalmic Society, Vision 2020 Right to Sight India, and Orbis International. This Vision 2020 Right to Sight was started in 2004, and at that time, it was decided that we'll achieve a goal of 25,000 ophthalmologists by the year 2020. And beside this, hospital-based paramedics, mainly optometrists and ophthalmic assistant, on 48,000. And for infrastructure, it was secondary and tertiary level service around 2,220 institutes in the country by the year 2020. So aim of this study is to assess the current status of human resource and infrastructure in country. And the objective was to obtain the estimate number of eye care institutes, services, along with number of ophthalmologists and ophthalmic paramedics in the country, and also to link this database to India Vision Atlas as a public web portal with easy access for patient as well as policymakers. We prepared the list of all the eye care institutes with the help of various databases. We got one from All India Ophthalmic Society, NIC portal of districts, Ayushman Bharat directories, and also website of various hospitals. When all the secondary and tertiary level eye care facilities were listed, which have at least one ophthalmologist, either part-time or full-time. A team of 30 staff members from RP Center, they use the full use of the work from home during the Corona time, and they were the coordinators for each state. And survey was using this online questionnaire, that is www.surveymonkey.com. And we contacted through emails. The question was filled through WhatsApp also, or through direct interviews also. And after that, virtual meetings were conducted with all the state program officers and district program officers in the country with the support of principal consultant, NPCB and VI. And they helped in data collection. We ensured data cleaning and validation. All the institutes were sent back the data for reconfirmation. As a result, I can show you that we were able to contact 8,790 institutes out of 9,440 listed. And out of them, 7,900. It's a big achievement for nearly 90% institute they responded. Among them, 27% were pediatric eye care institute. We use these specific indicators: eye institute population ratio, ophthalmologist population ratio, and optometrist or ophthalmic assistant per institute. Such kind of indicators were developed for India, for state, and as well as for every district. We recently used this indicator for filling WHO eye care situation analysis tool. In fact, more indicators can be developed as per the need of the policymakers, like pediatric eye institute population ratio, pediatric ophthalmologist population ratio. These are the indicators. Like, for example, we have one institute per 1,64,000 in our country, and state-wise distribution is also there. Color-coded maps are there. Ophthalmologists, like 20,944 ophthalmologists in the country, 1 per 65,000 against a target of 50 per 50,000. And optometrists, 2.26 optometrists per institute, total number was 17,856. In fact, these other indicators can be used. The respondents were 70% private hospitals. So we can distribute according to government, private and NGO sectors. Eye care services, emergency operation theater, eye bank, refractive surgery, low vision, respective indicators can be developed for these things. Then cataract, glaucoma, squint, VR, keratoplasty, oculoplasty, all these subspecialties were also asked. The best part which we could do is we could link all this data with India Vision Atlas to provide online information on human resource and infrastructure which will be useful for the policymakers and planners. This Vision Atlas was developed for National Blindness Survey by our team, and we just added on this human resource and infrastructure component in this Vision Atlas. And as you can see, this different indicators can be shown. Even the cursors can be moved to respective state. We can get the exact state data also. And we can get, if we go into that state, we can get the respective district. All the district data can be taken care of. We can also check the Eye Care Institute through this Vision Atlas. In fact, these filters are there. We can go to state, district, or even go facilities and all different services. And we can use these filters. We can even download the institute details with the help of these filters. This is something very positive features. And of course, we can also link this Vision Atlas with the Google map, so that the advantage of this, that even the layperson can find the nearest eye care facilities which are available to their home. So this is very useful. It can bridge the accessibility issues also. And what we are trying is that we can also incorporate newer institute or newer facilities into this Vision Atlas. That means it can be updated periodically. We don't need these surveys again and again. Institute can send their data, and it can be updated here only. To summarize that, adequate number of eye care institutes are there, at around 7,900 institutes against a target of 2,220 institutes at second and tertiary level. Ophthalmologists are 20,944 against a target of 25,000, nearly 80% is the number. Optometry and ophthalmics assistant are really lacking, just 17,856 against a target of 48,000. Vision Atlas can be very useful for planning eye care services at every district, state, and even at national level. And it can also bridge the accessibility issues faced by the underserved population by locating the nearest eye care facilities and available services. I'm really thankful to all the people, the ministry, SPOs, the AIOS, and our team members who are involved in this, who supported us. Thank you very much.
Praveen, this is a very good exercise which you have done. How do we actually make it useful for the people at large and in the villages? Because when you say that eye care facility can be approached, then person has to be a computer savvy person. So you have any further idea about extending this kind of advantage to the rural people?
So in rural areas where we have the PSCs, we have the referral facility, vision center, etc. If that person is good enough, he can be made aware of this Vision Atlas, and he can refer those patients to the nearest facilities available to them, sir. This is one approach. In fact, Government of India is trying to computerize even up to the sub-center level. If that can be done, that can be really helpful through Health and Wellness Center, where 1-2 people will be working in future, and 150,000 such health and wellness centers being developed in the country. 78,000 are already there, sir. So we are trying to move this component to up to health and center level, sir. Right?
I mean, one question.
Yes.
How does this Vision Atlas data link to the global Vision Atlas data actually? Because the data, how does it match with that?
Sir, it is not part of the IAPB Vision Atlas so far. It is the Indian data. What we realize in IAPB Vision Atlas is a very limited data, country-wise data. But here we have gone to the state level, to district level, up to the area like what we need in our country, sir. In fact, it can
state level data looks only what the national survey done by RP Center, doesn't include all other studies. There are multiple studies done in India. Probably that could be included as a part of this Vision Atlas, because all the studies in India should be incorporated as a part of Vision Atlas and not from only one study.
Yes,
That's
sir,
one
definitely.
thing.
It should be added, no doubt. In fact, we are in process of now developing this Vision Atlas, and we would like to add more and more data into this Vision Atlas. See, next 6 months it will be feasible, sir.
That would be great actually if all the Indian data is added. And is it also in the RAB repository or it's still not in the RAB repository?
It is already there in the RAB repository, sir.
Then
We
it
have
will
done
be used by
maximum
the-
number. Yeah.
Then it will be used by the global data also.
Yes, sir. Yes, sir. It is there, already there.
Second thing would be like this HR mapping. How is going to what's the implication in policy? Like what's going to be the next step?
Sir, it is very clear. In fact, what we are in discussion in ministry that we'll be holding planning for each and every district in the country. And in that way, we will be providing data about available human resource and infrastructure. And we have exactly what is the need. We can assess the gap. And then, of course, we'll try that. Both human resource and
The question is not of the availability. Question is about the distribution. The more issue is with the distribution because availability is there, but distribution is an issue.
Yes, this is as far as infrastructure is concerned, definitely availability is there. Human resource, we need human resource also. The best use is that with the help of Vision Atlas, we can exactly locate where the distribution and the location where we need it. So probably in future, this will be the most useful component in our country, sir. I feel this is our biggest achievement.
Yeah,
as far as
start, Praveen. It's a very
health
good start
expert.
actually as a good start, and I think we should build upon it rather than leaving it
Yes,
there and then. It should be a continuous process.
We'll be needing your support for this.
I am always there.
Was there any mechanism for cross-checking the data?
Sir, we have sent entire data to the respective institute and requested them to reconfirm if anything wrong is there. The best advantage is they can resend the data anytime, sir. Like even now, and we can incorporate the changes in this Vision Atlas. This is the major thing which we are bringing. There is no need to do such kind of survey every time in the country.
And it's
It's
high time,
dynamic.
Praveen, you should publish it also. You
Yes.
should publish the initial survey, still waiting for the paper to come out.
Thank you. Thank you very
So
much.
it's almost 2 years now. I think it's time to publish it.
It is, sir, under review, sir. Hope within 1 month you'll get it. Sir.
It's published 1 month. Good.
Hopefully.
No country has this kind of data, and I think we have the gold mine of this kind of data, and this kind of data from India would be much more useful for the entire world. Actually, it can go to.
We'll be very proud. This Vision Atlas is probably this human resource survey data is even more important even than the National Blindness Service.
Vision Atlas should build upon all the existing studies in India, and probably I think this study should go into publication.
We'll add on. We'll add on. Thank you very much. Thank you.
Well done, Praveen. Good.
Thank you,
Nice
sir.
job.
Thank you.
It's a huge work. I know it's a huge task to get all the information.
Thank you, sir. Thank you.
Thank you so much, doctors. Sir, Dr. Mihir is still not here.
Okay, then. Let's call it at the end.
Okay, doctor, not a problem.
Yeah. Before we close, just regards to Asim and Praveen and everybody. Seeing
Nice
you
to
after
see
a
you, sir.
pretty long time.
Yeah. At least it was an opportunity to see each other.
Yeah. That's true. So let's hope once this COVID is less, the community work will start again. Yeah, we are at the back benches now because of these problems, excepting Praveen, who is trying to work continuously.
Thank you, sir.
Anyway, it's a nice thing and nice to hear from all of you. See you again soon.
Thank you.
Thank you so much.
Thank
I
you, sir.
thank all the judges and speakers for the insightful session and keeping it on time. Thank you so much, doctors.
Okay.
By this,
Thank
we
you,
come
Raj,
to,
for holding it properly.
thank you so much, doctor. By this, we come to the end of the session. Thank you. Stay safe.